Hello, my name's Ian McCall. This is a short overview of erythema nodosum, and in this image diagnosis case. Here's the virtual slide and path presenter. You can see the pathology is in the septae. Sure, there's a little bit of inflammation in the surrounding lobules as well, and this isn't uncommon. What you're going to see in erythema nodosum just depends at the stage at which you biopsy this lesion. Now, very early on, the cellular infiltrate in here is likely to be neutrophilic. But later that changes. It becomes more lymphocytic, and as time goes on, you get fibrosis in here, and you may also get granulomas and giant cells. So at this sort of level, you can see the background fibrosis. This is a later lesion. It's not necessarily an acute one. There is some inflammation involving the adjacent lobules, a little bit of red cell extravasation here. It's usually looked on as a septal vasculitis. The condition, can be associated with a variety of conditions. Sarcoidosis is probably one of the commonest. We always look for sarcoid in a patient if they present with erythema nodosum. But also infections, both bacterial and fungal, and certainly also in the inflammatory bowel diseases. Crohn's, ulcerative colitis, Behçet syndrome, Sweet syndrome as well. And a few drugs, particularly oral contraceptives, women coming off the oral contraceptives, but also sulfonamides. A lot of cases can be idiopathic. One of the commonest causes of erythema nodosum is a patient being with labromatous leprosy who's being treated. It's a reaction pattern to the drug treatment, but that's only in certain parts of the world. So early stages neutrophils, later on lymphocytes, histiocytes, granulomas, some extravasated red cells, and a septal vasculitis. There's a thing called Meuscher's radiogranulomata, and these are histiocytes in a radial arrangement around the central cleft. I was just looking here to see if we could see any clefts, but the short answer is no, we can't. And further on you go, the more fibrosis you're going to see in the septae here. But that's a fairly classic picture of erythema nodosum. Here you see some giant cells in this particular case here. If vessels are involved, it's usually going to be veins, and often you'll just see a bit of thickening of the vessel wall. Sure, there's a little bit of red cell extravasation here. Some of the giant cells in this component, the older the lesion is, the more likely you are to see these giant cells. Multinucleated giant cells here as well. Anytime you've got lots of granulomas with giant cells, always just have a look and make sure it's not an infective paniculitis that you've got. Occasionally the veins will show obstruction with some thrombosis and hemorrhage. But most cases, the vasculitis, if it's occurring, is it's not frank. It's just a very mild process. The overlying dermis can sometimes show a bit of a superficial deep perivascular infiltrate. Sometimes some also inflammation around some adnexal structures, but it's patently obvious with a deep biopsy where the pathology is. So septal paniculitis, erythema nodosum. Thanks very much.